Today I have with me Dr. Elayne Lansford. She has a private practice in Austin, Texas. Um, she works there as a licensed clinical psychologist, and I heard about her through reading one of Dr. Stephen Finn's books, and he studied a little bit of control mastery theory, and he mentioned Dr. Elayne Lansford by name. And so I reached out to her in hopes that she would discuss just her practice and her work along with control mastery theory with me, and she's graciously decided to do so. So, Elayne, thank you for joining us today.
My pleasure.
Yeah, it's a real pleasure to meet with you, and I was just wondering if you could kind of start by telling us what got you into psychology in the first place.
Well, I when I was an early adolescent, I felt a calling to it.
Okay.
And so since I was about 13, I thought, if I'm worthy of it, this is what I want to do.
Oh.
So I proceeded to try to get experience for myself, and of course got a degree in psychology and got my first job at the Austin State Hospital, which was both lovely and gruesome at the same time. Lovely because of the people, gruesome because of what mental hospitals were like in the 1970s in Texas, at least. But I figured that if I could do all right with that, then probably it made sense to go ahead and get a graduate degree.
Okay. What kind of exposure did you have as a 13-year-old girl to psychology?
Actually, very little, although I think that psychology today came into being somewhere around that time. And I certainly, I remember reading it when I was young, but I can't remember. Someone might have exposed me to Jung, and I'm not a Jungian, but of course, I really can't remember how that came about.
Okay, interesting. And then so you were exposed at a young age, you did some reading, and then you you got your bachelor's? And then you went straight into working at a hospital with your bachelor's? Okay.
Yeah, as the lowest of the low, a mental, I think they called us mental health workers, which was sort of equivalent to lackeys. We did, whatever had to be done that for the lowest people on the hierarchy.
No, you didn't do any type of like therapy. You did. Oh, what did you do?
Largely, it was kind of, crowd control in a lot of ways. But we were actually back then, if we came up with an idea about a group, it could be pitched to our superiors, and they generally allowed us to do it.
Oh, cool.
So I can remember, having, groups just to try to help orient schizophrenics. And then at a later date, when I worked in more of a halfway house setting at the state hospital, trying to, teach people yoga and in all manner of things.
That's very pleasant.
So there was a lot more freedom back then, and anything that involved care of people who'd essentially been forgotten by society seemed to be appreciated. So,
good. I'm sure you made a very positive impact while you were there. You mentioned that it was gruesome in some aspects, at least at that hospital in Texas. Can you tell a little bit about the negative parts of it? How were people treated? Or
well, it was the first place I worked admitted off the streets of Houston, essentially. So every poor soul who showed significant mental health impairment just got sent up to the state hospital for a while. But some of the staff had been there for a very long time and were there when it was almost back when it was a lunatic asylum. And they still had the chains in the basement of the main building where they used to chain the inmates.
Wow.
So some of the people were pretty harsh, and
Mm.
they didn't treat the patients like they were people.
Yeah.
And it also was a rough situation in that there were many, many patients and not that good of a staff ratio.
Mm-hmm.
So awful things could happen to patients at the hands of other patients.
Mm.
And then periodically we would get someone very, very violent as
Mm.
well as being mentally ill. And I remember when at one point there was a woman who'd taken out almost all of the male staff. And
Mm.
in those days, they didn't require women to do restraints. We were taught how to, but I guess because we were female, we were left alone. But the guys had to do it.
Mm.
And this particular person had injured almost every single man on staff. So
Wow.
she got sent away to the hospital for the criminally insane.
Mm. Wow.
But so it was, and people that, you know, that I remember that people were given free packs of this tobacco called Bugler. And I believe it was what was swept off the floor of the tobacco companies. It was this really nasty unrolled tobacco. So you had like hundreds of people rolling these cigarettes and smoking Bugler and just sort of this gray haze over the whole unit. So it wasn't a pleasant atmosphere.
Yeah. Yeah. I I don't have any experience in that type of a setting. I'm reading a book right now by um a lady who has her doctorate, and she works in that setting, and she's talking about even now, like, you know, people with schizophrenia, they put them in this hospital and they're away from their friends and they're away from their families, and then you have like everyone that's not a patient is an authority figure. And she was just kind of mentioning how in that scenario, like what type of a mental health problem is going to be resolved in that setting, or how much good is that doing the person. And I think we've come a long ways, but we still have a long ways to go.
Yeah.
Yeah.
Yeah. No, it was somewhat of a warehouse situation.
Mm.
Although oddly enough, a number of prominent Austin musicians had their start as not as inmates, you know, as patients, but as mental health workers at the Austin State Hospital.
Oh, really? Very interesting.
So I don't know what that has to do with anything, but it's
Yeah.
a little factoid.
And then how many years were you there?
Just a couple years.
Okay. And then you went to continue your graduate studies, to get your
Right.
doctorate.
I went to University of Michigan.
Oh, okay, Michigan. And was that kind of like a generalist degree? Was there a certain orientation that was taught at that
Oh,
time?
no, it was heavily, heavily psychoanalytic.
Oh,
I
okay.
think at that time, Michigan and Adelphi, I was told, were the two most psychoanalytic training programs in the country.
Oh, okay, cool.
So
And what,
it was
yeah.
intense.
Was it, did they teach more of like Freudian, or you said you're not a Jungian? Was it like classical or neo-Freudian, or?
No, it was very classical Freudian.
Okay.
Drives and superego and id and Oedipus complex, and kind of moving into object relations. But Kohut, people could handle Kernberg, you know, because he was very object relational and he would talk about, you know, borderline personality. But Kohut was considered a little too radical in some way. So it was, if you wanted to learn about Kohut at that time, you needed to do more reading on your own.
Oh, okay,
So
interesting.
it was very old fashioned, but very bright people, superbly trained. And if one wished to, one would get out of that program with a very solid grounding in psychoanalytic theory.
Good. And do you still kind of hold to that classical Freudian, or do you keep it in the back of your mind? Is it because to kind of orient your, yeah,
Now, I keep it in the back of my mind. I
yeah,
had my doubts even then
okay,
about it, seemed to me it was a worldview and that did not necessarily encompass all of the data in
mm,
the best way. Uh, but it was a very coherent worldview. And
mm,
I think that, Freud's wish to make the unconscious conscious, to help people understand things, to use language in
mhm,
order to be able to, as a part of dealing with their suffering. I mean, that's very much with me.
mm, yeah. Do
But
you,
as far as the classical Freudian theory, I think even among the analytic people, that is now, the psychoanalytic thought has gone off in very different directions.
mm, yeah. Do you, do you subscribe to the, like, as long as your client can love and work, that's kind of like the, or what is your kind of, yeah.
Yeah, no, I think I thought that was quite beautiful. But
Uh,
on the other hand, Freud's idea that, what was it? We were turning neurotic misery into everyday human suffering. That really didn't resonate with me.
mm,
Uh, but then Freud was European, and I think had a much more tragic view
mm,
of humankind, whereas most American psychology, we're an optimistic bunch
uh-huh.
and tend to prefer happier endings.
Yeah, yeah. And so now with the way that you practice, what would be kind of your I guess, how would you know when the work is finished?
When the work is finished.
Is there a finishing?
Yeah,
Yeah.
no, or there's a finishing enough,
Okay.
and the way I practice is I generally tell people, I mean, we say goodbye and we talk about what the work meant,
Uh-huh.
but they're always welcome to return if they would
Mm,
want to. So it's a little less, I think some theoretical uh, kind of approaches would involve a very solid termination. And
uh-huh.
I do it a little more in what once was called the family practice model. I worked in a medical clinic for many years, and I like that idea that people are free to return if they need to.
Mm. And I guess, how do you know when to say goodbye for the first time?
Generally, I think my client and I both realize it. If the alliance is strong,
Mm,
it's a mutually felt sense that
mm,
we've done about what we needed to do.
uh-huh.
And, on one level, they have many more coping skills and they seem to be able to regulate their emotion.
Mm,
On another way of saying that is that's more psychoanalytic is they have an internalized sense of me, or me kind of agglomerated with a lot of other benign others. So they have something internal
mm,
that they no longer have to turn to. They're carrying it inside.
yeah.
And I find that in good terminations, we almost always realize at about the same point that it
Mm,
seems like the work is done.
yeah. I like that. And okay, so when you finished your graduate training, what did you do next?
Then I went to San Antonio
Mm,
to do a postdoctoral fellowship for a couple years.
okay.
And I would add that while I was at Michigan, I managed to find just a fabulous mentor
Mm,
who his name was Ed Borden. He's kind of a minor, but very, I think, well respected and well liked. He was a psychotherapy researcher,
uh,
and he was terrifically interested in the universality of what was healing in
mm,
psychotherapy.
mhm,
So I wouldn't say he was a favorite in the heavily psychoanalytic crowd at
mm,
Michigan, I mean, even though he was analytically trained, but they thought him a bit of an upstart because he really was just, he felt that for him, the crux of everything was the working alliance. And that was what his research was on. So he introduced me to the literature on psychotherapy research, which I found fascinating. And back then, other than Menninger's, there was no research to speak of on psychoanalytic therapy. Psychodynamic, Strupp and Luborsky had done work, and others as well. But it was kind of a little bit different look at the world of psychotherapy, and I loved it.
And so you got straight into research then?
Well, I did, but no, I haven't. I'm too fond of people and a little too not quite as cerebral as one might need to be a really good researcher. So I did a little and made a decision that I didn't want to. I mean, Dr. Borden was willing to shepherd me into an academic career, but I didn't think that was the right place.
Yeah.
But I kept my love of, my parents were scientists, and although I'm much more emotionally based, I've always loved things that had data behind them, not in a rigid way, but just, we all have ideas about things, but why not investigate it to see if it really seems to hold up?
Yeah. So that reminds me, so with control mastery theory, from what I understand, the president of the current San Francisco research, I can't think of the name.
Psychotherapy research group. Yeah.
Yes, yeah. He talked about getting into it because he was interested in what makes psychotherapy work. And and I think he's found a lot of the answers in control mastery theory and the way that they understand case formation. And would you agree that is that kind of what drew you to control mastery theory, or do you agree with the data behind that? And
absolutely. I had studied psychotherapy research, and Ed Borden in passing one day said, "Oh, you might want to check out those people at Mount Zion. They're doing some interesting things." And I remember this was, of course, in the days of snail mail. So I wrote them a letter and begged some articles, and they mailed them to me. And when I read them, their psychotherapy research was head and shoulders above most of the other psychotherapy research, which was outcome-based, looking at scales of this and that, and it's very legitimate research. But I could tell that whatever they were doing with control mastery was way deeper, and I just thought, I have to learn this stuff. So I very concertedly had to work to get myself educated, because I didn't live in California, where the bulk of the practitioners are.
Yeah.
But I just find it amazing. I mean, that was the most joyous moment to really begin to understand control mastery theory.
Okay. That's good to hear. I say this in jest, but I talked with Dr. George Silberschatz about control mastery theory. And so I was thinking, I'd like to hear it from someone who's not the president, because he's probably pretty biased, but no, yeah.
Yeah, no, he would have more reason to speak well of it. And I, on the other hand, am a little more of a free agent. But the thing about control mastery theory is, once one has the fundamental concepts of that patients have pathogenic beliefs, which I think a lot of us would argue may have a lot of affective component as well. It's not the same thing as a maladaptive belief in cognitive behavioral therapy. Much more, actually more similar to Bowlby's internal working models. in a lot of ways. But once you understand somebody's pathogenic beliefs and you understand that your work as a therapist is to help them disconfirm these beliefs that have been crippling them or oppressing them and holding them back, then you have an incredible amount of freedom. And of course, with psychoanalytic theory, everything was pretty carefully orchestrated. One wore a certain kind of clothing, one said a certain kind of greeting, one, always, almost everything had to be responded to with what are your thoughts about that and so forth. And it's just a very formal kind of way of doing things, and people could and get very stuck in the technique of it all. And although there are benefits to that, and I'm sure that there are many good therapists who like to work that way, but there's some of us who want the big picture in mind, then love the freedom to be able to work in different ways. And if control mastery gave me anything, it was two things: a very deep conceptual understanding of what was going on in my people, and then the freedom to be able to respond to them without the same internal constraint.
Okay, sorry. I lost internet connection there, but we dropped off while Elayne was discussing control mastery theory. So sorry, go ahead, please.
Okay. Well, there's once somebody understands the fundamental concepts and what it is that their client needs from them, they're free to respond in a great variety of ways. And it doesn't have to be the classical psychoanalytic. It doesn't, and it can be very unconventional. Joe Weiss had a schizophrenic patient to whom he gave a woman, and he would give her little tiny gifts from time to time. And I think I believe I remember him explaining that one of her pathogenic beliefs was that she was very unworthy. And heaven knows mentally ill people often feel that way. And that these giving of small gifts to her was a way of confirming, to her that she was worthy.
Yeah.
And I mean, oh my word, if you'd done that at Michigan, ooh, it would have been not pleasant.
Yeah. It's unethical, basically, right? Like, that's what they would say.
It would have been. Yeah. So it was just, and there are reasons for that. But I liked that. I thought I had a feeling that somehow what he did probably advanced things more for her. And I'm certainly not speaking of failing to have boundaries. And the good control mastery people all have very good boundaries, but they feel freer within those boundaries. And I loved it because one can also incorporate other work. And I discovered cognitive behaviorism at Michigan, and remember that I would check out, books by Meichenbaum at the library, and then I would hide them in the middle of my psychoanalytic books when I went to classes, because it would not have been good if anyone had known that I was reading them. But I thought, I didn't know that was my preferred style, but I thought there are such important things going on here. And why can't we consider in a thoughtful way, incorporating some of this kind of work? And with control mastery theory, it really doesn't matter what technique you use. You just want to work in a way that's pro-plan.
Yeah.
And I supervise students for, it's probably been 35 years now at the University of Texas, which is a very high quality cognitive behavioral program. And those guys don't get anything but cognitive behavioral work unless they're interested. And then they could come and meet with me, and at one point some other supervisors too.
Uh-huh.
And they would do their cognitive behavioral work, but I would just help them understand what lay behind
Mm.
the person in terms of control mastery theory, what their pathogenic beliefs were, and made sure that the interventions they did were going to disconfirm the beliefs,
Mm.
kind of telling the patient what they hoped, which is they don't have to believe in the way that they did, or
Mm.
whether inadvertently they'd confirmed them. But it was really a lot of fun in that this is totally a different theory, and yet we managed to use the concepts, and they had, just did lovely therapies with clients.
Oh, that's great. That's wonderful. It's funny. It's you mentioned you would bury the cognitive behavioral type books amongst your psychoanalytic books, and a lot of the schools now, like maybe perhaps the University of Texas. I know here we joke we're kind of heavily CBT here, and we have one psychodynamic or two psychodynamic faculty. They mainly practice psychodynamically, and we always kind of joke that they're like, hey, you like psychodynamic? Like, hey, let's talk. Like, yeah. You gotta sneak around.
Yep. Yeah. No, it's so funny how, yeah, the pendulum swings so
Mm,
much.
yeah. And so how did you, in order to learn control mastery theory, did you get like certified? And how did that, what was the
You know,
training like with you being in Texas?
it was, I went to a seminar that Joe Weiss and one of his proteges
Oh,
taught at Cape Cod. And
okay.
then the San Francisco Psychotherapy Research Group had an annual conference
Mm,
that was open to people both in the United States and internationally. And I know that Dr. Silvershot's, although it may be online now and it's shorter, it used to be a week. So
okay.
you could go and just spend a week in San Francisco, and it was quite lovely.
Mm,
So I would go to those, and then I found myself a supervisor,
oh,
and I did telephone supervision. Oh, perhaps for 20 years. I mean,
wow.
because I realized I would not learn it. So
Yeah.
it's both simple and complex.
Yeah.
That conceptually it's very simple, but uh, I felt like I really needed help in learning it.
Mm,
So I spent a fair amount of time just getting that supervision.
mm.
And then eventually I went on to present papers and teach, and I started teaching people at UT and so on.
Do you still teach it?
Very little.
Okay.
I would be open to it, but as things have changed,
Mm,
there is less openness to that.
mm,
And I think there's also more pressure on the students, so that making a choice to do something a little outside of the mainstream, that they just don't have as much bandwidth.
yeah. Yeah. This might be a funny question, but do you remember teaching? Do you remember Dr. Stephen Finn being one of your students?
Oh, well, he was not actually, for a little while, I taught courses in the community, and
Okay.
he took a course for me, but he actually was the clinical director at one point when I was on adjunct faculty there. So I met
Oh.
Steve through getting together with him because he wanted to, kind of evaluate the people supervising and make sure that they were of adequate quality and so
Oh,
forth.
okay.
So yeah, we've known each other for a very long time.
Oh, good. He's a yeah, very nice guy. Very nice man.
Oh yeah, no, he's fabulous and so kind of, you know, gifted and knowledgeable in his realm.
Yeah. Okay. And then did you, how long until you started your own kind of private practice?
Um, I worked for 8 years in a multi-specialty medical clinic
Okay.
when I finished my postdoc. And eventually, and then after that, in the early 90s, I decided that it was time to go into private practice. So been in private practice since then.
Okay. And yeah, so before we started kind of recording, I made mention of your beautiful room. And if you check your website, you kind of emphasize like the garden around your practice, and like there's like pictures of flowers and birds, and it's all very lovely. And can you kind of talk a little bit about that in your practice?
Sure.
Yeah.
Well, and that's not meant to be a major part, but I just figured if people were trying to make a choice of therapists,
Uh-huh.
sometimes seeing those sorts of things would be useful.
Yeah.
I don't regularly, that there's no part of the therapy that's specific to that,
Uh-huh.
except for the fact that in the pandemic, because we couldn't meet indoors, and this is Texas after all, I met a great number of people out in the garden. And
Oh,
that
okay.
turned out to be quite lovely. If it
Yeah.
was summer, we'd sit in the Balinese pavilion by the pond and there would be a fan on. And if it was winter, we'd go into the bottle world because the sun shone brightly there and so forth. And it was, I don't know, some people say that they find it very calming to be in nature. And if you
Mm,
look at the data on what nature does for people,
mhm.
then that tends to show up very steadily.
Uh-huh.
But it was never a primary intent. It's just sort of a secondary benefit.
Yeah, because it is a very lovely. I'd rather sit in this room that you have here than sit in a dark office with gray walls and paintings. I don't know.
Yeah.
Yeah.
Yeah. I read something recently that some people were looking now into the idea of doing therapy while people were walking. And I found that interesting. I've had a few clients who actually, I live on acreage, so we have about 30 acres of woods behind the house. And
Nice.
if they want to walk on the trails in the woods, it's very private. And that was very interesting. I couldn't tell you whether it was better or worse.
Mm,
And again, I know no data about that, but I think as the somatic approaches are more and more prominent nowadays,
uh-huh.
there's the idea of could somehow things be processed in a different way if movement was involved.
Mm, that's very interesting. I've I've kind of talked with my wife about like I like the idea. I'm very far away from it, but I like the idea of having maybe an in-home private practice with maybe a garden out back. And we talked about, with certain clients, especially maybe ones who are depressed, and if you want to take them outside on a nice sunny day and walk through the garden and do therapy that way, like that might be good for all sorts of reasons. And
Well, and I have done that on occasion with
mm,
very depressed people.
mm,
I said, we need a little, and this, of course, is your language. We need some behavioral activation
yeah,
here. And you're going to come out and walk just a wee bit. And then, and I think that that absolutely can help. I don't think there is any data yet
mm,
on whether if you walk with people and talk,
uh-huh,
you often are not making eye contact.
mm,
And eye contact is, I mean, that's how neurologically our brains connect.
uh-huh,
So that's the downside.
uh-huh.
But the upside is sometimes I think some people, as they're moving, might feel a little more able to formulate certain things.
Yeah. Yeah, that's very interesting. My mind first just went to like in certain circumstances, like let's say in psychoanalytic psychotherapy, you might have someone very classical old style, like lie on the couch and free associate or something. And that's not going to be eye contact. And then I thought I had a client the other day who normally we kind of just sit and we talk. But the other day we did some kind of drawings on a whiteboard,
Mhm.
and he said he liked it a lot more that it brought up as we were drawing, and it brought up a lot more thoughts and memories and just emotions that he could kind of talk about.
Mhm.
Whereas when he's just sitting there, sometimes his mind is kind of blank. And so that was
Mhm.
just interesting. That's what my mind went
Yeah.
to.
No, I think we'll probably grow to understand more about that
Mm.
in a data-based way
Uh-huh.
in upcoming years. And I
Yeah.
think that, all for the best.
Yeah. That was exciting. And okay. And then how about you just kind of talk about your private practice and what do you have any areas of like special interest or that you most prefer, or like do you have any, I don't know, limits or like maybe
Yeah.
you don't see 4-year-olds. I don't know.
Sure. Well, yeah. I have always been more of a generalist in that I didn't want to specialize in any given area.
Hmm.
But having said that, that I do control mastery is the predominant theory that's kind of underneath everything.
Okay.
I will do cognitive behavioral work when I think it's warranted.
Hmm.
And for example, with anxiety disorders, I believe that the data is very robust, that people initially are more helped by a cognitive behavioral approach
Hmm.
than an analytic one.
Uh,
And I mean, sometimes as people go further, they may come to understand the origins of their
hmm.
anxiety. So I'll do some cognitive behavioral work. I also uh, I have some training in systems theory,
Okay.
and I love to do couples work, and I love to just think about family systems
Oh.
because they're the most, complex and fascinating and exasperating and lovely, and all of that.
Uh-huh.
So I'll do that kind of work. Um, and I work with trauma to a certain degree,
Hmm.
not the most severe trauma, the
Hmm.
very, very, but I certainly know more about trauma than I think than some people do, and
Mhm.
find that it's really an amazing area in which to
Hmm.
work.
Yeah.
And then I think the one other area, most specifically, is I've always been interested in how people managed illness, kind of almost like behavioral medicine,
Hmm.
except a little less scripted. But I've worked with a lot of people who had chronic illness, and it could range from autoimmune illness to
Hmm.
cancer to not so much the brain injuries because I'm not neurologically trained,
Uh-huh.
but just how to make meaning in a life where one ends up being very limited
Hmm.
by physical constraints or pain.
Yeah. Yeah. Okay.
So you can
Um,
see it's kind of a melange, and
yeah.
I don't like to work with perpetrators.
Okay.
I'm not trained to do that, nor in many cases, certainly like with domestic violence, the data is real clear that a group setting is far more effective.
Hmm.
So, I don't work with them. Uh, don't work with young children because I have no training. I mean, and I as I because I work out at my home,
Uh-huh.
I am not inclined to accept people that I think might be dangerous in some way.
That makes sense. Yeah.
And I so I do some screening in terms of if I think people are highly aggressive and impulsive,
Hmm.
then we're just not the right fit for one another.
Hmm. Hmm. Oh, Okay, so your private practice is like an in-home private practice?
Well, I have a little dedicated office that's it's a bit of ways from my home,
Uh-huh.
but anyone who came to see me absolutely knows where I live.
Okay.
So there's that.
Yeah.
And when people do that, I mean, in-home offices work very well if they can be more selective
Mm-hmm.
in their practice.
Uh-huh.
And mostly that, and most clients are not going to be dangerous. But
Mm.
for example, when I was younger, I sometimes worked with women who were attempting to leave marriages where
Mm.
partners were pretty coercive and abusive.
Uh-huh.
And that would not be a kind of situation that I would feel comfortable to accept now.
Mm. That makes sense. So when I talked with my wife about having an in-home practice one day, that's one of the things that she brought up was, I wonder how that works with certain clients um, and screening them and such as you said.
Yeah,
Yeah.
you have to be able to screen.
Mm.
And that means that you have to be at a point in your practice. Like in the beginning, most of us, as long as we feel qualified to treat,
Uh-huh.
we'll try most everything.
Uh-huh.
You know, when I
Yeah.
went into private practice, I was quite willing if people called me and wanted to be seen, as long as I felt that I was qualified,
Uh-huh.
I'd give it a try. And as you
Uh-huh.
get more experience, you learn, oh, I'm not as good with people like that,
Mm.
and then they're the ones who mean business and are really going to work. And
Yeah.
although I'm not as impatient as some of my colleagues, I have some who basically say they're not willing to work, I'm not willing to see them.
I see. Um, yeah, and then I was telling someone, I think just yesterday, about the idea of an in-home practice, and they asked me if I've ever seen the movie What About Bob? And I don't think that's likely, but
No, I do not think that's likely. And I have known many people. Well, I don't know if I'd say many, but I've known a number of people who had practices in their home,
uh,
and in some cases, actually, literally in their home. So
mm,
you had to walk in the front door to get to the room that was their office.
yeah,
And I have never heard of anybody I've actually never heard of anyone getting in difficulty with it. But again, if you were seeing a certain, like there's a man in Austin who had a specialty with antisocial people,
mm,
and my guess is that he probably saw them
uh-huh.
in an
Yeah,
office building.
yeah, that makes sense. Okay, how much longer do you kind of plan on practicing, or have you no reason to think about that?
No, I have thought about it.
Uh-huh.
Uh, I absolutely love the work.
Mm,
And just right now, I can't imagine not doing it.
yeah.
But I'm also at 66.
Mm,
I'm at the age where I've seen people practice too long.
uh-huh.
And although none of us ever wants to become demented, there is that there's a time
Mm,
when we need to leave. Or even in one case, I had a colleague who was very, very physically ill
mm,
and should have stopped practicing and did not do so. And as a result, some errors were made that I think had she been stronger,
uh-huh.
because she was a really very reputable and good person.
Mhm,
So on one hand, I love it, love it, love it, and want to
uh-huh.
keep doing it. And on the other hand, if I, get to the point where I'm doddering in any way, then
Yeah.
I think, oh, time to go.
Yeah.
And the thing about a practice at home is that it's very easy to do.
Mm.
Some of my clients tease me about my commute and how rough it is. And also, I have no overhead. I own the building. I built it, out of money I saved.
Yeah.
So it becomes possible to practice very, very minimally
Mm.
in a way that for someone like yourself, you're going to have office rent and it just isn't feasible.
Yeah.
I don't, my guess is that somewhere or by the time I'm 70, I may want to be slower, but we'll see whether I want to just slow down and see a few people for a bit longer or whether it's time to go.
Yeah. Yeah, that makes sense. And one of the things I love about this profession is I grew up in like country Ohio. You build houses or you work in a factory and
Oh,
yeah. And so one of the things I love about this is that as long as, like you said, as long as your cognitive and your physical health is good, then you can practice right up until the end, basically,
yeah, in that way, it's a very intellectual profession.
Yeah,
And it's lovely because the older we get, presumably the wiser we get.
hopefully, yeah.
And so there's, one would hope so. And so we actually have more to bring
Mm,
to
mhm,
the treatment. And there are a lot of professions where, if it's an athletic profession, dance or sports, people absolutely have a shelf life. And then, if you're in, marketing or IT,
yeah,
those are places where if you're over 40, you better be damnably good at what you're doing
uh-huh,
because otherwise you're viewed with suspicion.
mm,
And it's lovely because there's so much freedom and capacity just to keep going,
mm,
and there's flexibility
uh-huh.
that I really, if people are suited to being therapists, it's such a fabulous profession.
I love the enthusiasm that you bring to the conversation. Yes. Um, I guess maybe my last question. Um, hmm, what kind of advice would you have for the up and coming clinicians and psychologists? Maybe some words of wisdom or just yeah.
Well, goodness, I think I would absolutely encourage people to learn as much as they can.
Hmm.
And it doesn't mean that I think being eclectic is always the way to go,
Uh-huh.
but simply, try to see what's out there
Hmm.
because it's a fascinating profession and rapidly changing
Uh-huh.
in a lot of ways. So it would be keeping an open mind. And then the other thing that I would really urge people to do is to make sure that they take care of themselves,
Hmm.
because most of us who go into therapy feel a little responsible, or we wouldn't bother with we do something more frivolous,
Uh-huh.
and it's easy to get over responsible, and sometimes it's easy to get too worn out.
Hmm.
And although their psychology is infinitely better than medicine about self-care. I
Hmm.
have a son who's a young physician,
Okay.
and I was really appalled at their feeble attempts at teaching self-care in
Hmm.
medicine. And my experience is a lot of physicians really they have not had help to learn that.
Uh-huh.
Psychology's better, but even so, I think it's hard to help other people unless we feel centered and grounded in some way.
Yeah.
And that involves sometimes getting away from it. It involves always having people to talk to.
Hmm.
No matter how experienced, we still need our sounding boards.
Hmm.
And just knowing that the way we help other people is that we take good care of ourselves too.
Yeah. Good. Good. Well, Elayne, it's been a very pleasant conversation. You're a very beautiful person, and I appreciate you coming on to talk with me.
Well,
Um,
my pleasure. And I certainly wish you and all of your listeners all the best in kind of, sort of being, keeping psychology going on, because
Oh,
it's a lovely profession.
oh, good. Thank you. Thank you so much.
Okay, bye-bye.
Bye bye.